Today we're going to be talking about evidence-based practice and how it sets the stage as we continue our work through this pathophysiology and pharmacology course. We're going to also touch base on what pharmacokinetics means and how you need to interpret the information related to the pharmacokinetics of the many drugs that you administer as a nurse. First, let's look at evidence-based practice. This provides information for healthcare providers, physicians, as well as nurses, the best practice to carry out procedures, administration of medications in this aspect, as well as different interventions to improve patient health outcomes. Effective healthcare is a system through the AHRQ, which you will read more about in the textbook readings for this module. A systemic review is a review of the literature for all research studies, from clinical trials, which is the highest level of evidence, down to small sample studies or non-randomized sample studies, as well as limited case studies. But again, it all adds to the evidence to the development of best practices. For this course, we're going to be looking at clinical practice guidelines, which guide the prescription of certain medications to treat and manage the health problems of patients. We're going to touch on the more commonly occurring health problems such as hypertension, dyslipidemia, respiratory problems. We're going to be going through an evolving case study as a patient evolves through the 7.5 weeks of this course. So again, you're not going to be in the prescribing role because that's an advanced practice role. You're going to be in your nursing role. Patient is going to be prescribed medications based on his assessment findings and laboratory findings. Then you in your nurse's role will compare the medications that have been prescribed to the National Practice Guidelines, which is evidence-based practice, and you will determine if there's a change needed in the person's medication plan. Again, it's not an advanced practice role, but you will be becoming familiar with the national practice standards that are out there, and you will be able to judge if the medications that are prescribed by the patient's healthcare provider are accurate and effective. This little diagram is a photo. It shows how pharmacotherapy, the administration of medications, is important. Again, if you look in the top, this is a picture of a patient that looks like a hospitalized patient in a hospital bed. Just keep in mind that this person could be in the home setting. He could be seen in a clinic or primary care physician's office. The clinical setting does not make a difference. These principles will be hold true through all clinical practice settings. We're going to really focus mostly on the signs and symptoms of disease this person is exhibiting. Medications are going to be the intervention of choice for this course. And again, you would expect to see decreased signs and symptoms and overall patient feeling much better. This is the pharmacology, pharmacotherapy, and the pathophysiology is here. You need to understand why this person is having the signs and symptoms of the disease process. The pathophysiology will explain why, if someone has pneumonia, the signs and symptoms would be a cough. So again, the pathophysiological changes will explain why that person has a cough. Medications are given, and then you would expect to see improvement and a decrease in these signs and symptoms. That's the connection between pathophysiology and pharmacology. Here's a question for us to talk about. Is there a perfect drug out there in today's world? Obviously the answer is no, because if it was the perfect drug, it would do everything that you wanted to do without any side effects. It would be very convenient to obtain and convenient to administer. Be very inexpensive, no drug-to-drug or no drug-to-food interactions, and it could be quickly eliminated from someone's system, so there would be less side effects. So obviously this is the goal, but it's not. We're nowhere near that yet. Drug actions, there's many drugs that are introduced every year that have to go through the FDA approval, through the clinical trials to make sure that they're safe. Drugs can improve the quality of life. They can improve the health problems that our patients experience. But again, on the other hand, there are also many drug reactions that can cause disability or even death from the drug adverse effects. So it's a very hard job for you as nurses to stay current in all these new medications, and especially on the administration of medications to patients. Let's talk about bioavailability. Here's the definition. Again, bioavailability has to relates to the active ingredients that are absorbed from a drug product and that's available where the action is needed. There may be a slight difference between trade and generic names of drugs. Most often they can be interchanged, and obviously the generic format of a drug is cheaper and more cost effective for the patient. There are some medications that may vary between the trade name and the generic name. It has to do with the fillers, the dyes, the colors. Again, they may interfere with the active ingredient of the drug itself working effectively. This is very few. Synthroid, you may have heard, thyroid medications, the bioavailability of Synthroid may be differ as you get into the more generic formats. There's other medications, but not that many. I just wanted to bring this to your attention. A lot of patients out there are getting on a lot of medications. As someone as age in the elderly population, they could be taking maybe 7 drugs or more a day. Drugs are expensive, so they are looking to the internet for drug sales. Again, the advertisements and the cost is much cheaper than if you were purchasing drugs through a pharmacy here in the United States. You have to remember that quality control standards may differ. The sources may be unreliable. Drug laws are varying from country to country, so you have to worry about the quality of those medications. So you as a nurse must be a patient's advocate and help them understand the differences and the dangers of obtaining drugs from different countries. Now we're going to move into pharmacokinetics. Pharmacokinetics consists of absorption, distribution, metabolism, and excretion of drugs. We're going to be looking at each section of these as we go through today's work. But you can see the oral drugs are swallowed through the GI tract, go through the stomach, some absorption is taking place, the rest is going into the small intestine, and there's further absorption taking place. Absorption is when the drug moves into the bloodstream. If you're given an intravenous medication, it bypasses the GI tract and it's administered directly into the bloodstream and ready for distribution. Distribution will take it to the organs, the body cells, where it's needed. After the action is done, the drug goes into the liver, and almost all the drugs are metabolized in the liver. So again, that's when you're taking care of a patient, you have to remember if they have liver disease, either cancer of the liver or cirrhosis. You have to make sure you're watching the toxic level of those drugs because the metabolism of the drugs will be slowed. After they get metabolized back into the bloodstream, into the organs of excretion, which most drugs are excreted through the kidney. And again, this is another reason why patients with kidney failure, you have to watch the toxic levels too, because the excretion of the drug is slowed. Talk more about absorption. Like I said, it's the movement from the site of administration into the bloodstream. So again, if it's oral, it's going from the oral to the GI tract into the blood. If it's intravenous, it's going directly into the blood, so you don't have to there is no absorption phase. Contrast medias for radiology is the barium, so these drugs aren't absorbed. Probably some of you have taken care of patients who have had barium enemas or barium swallows, and you know that they have to pass that barium out to the GI tract, and you know it's done because of the change of the stool color. There's a lot of factors that affect absorption, and we're going to be talking about a little bit more into the pharmacodynamics and the pharmacogenetics phase, because some patients absorb drugs differently than others. But obviously oral drugs must first be dissolved and then transfer into the bloodstream. And depending on the administration, the route is how fast they absorb. Let's just go back a minute. The condition of the GI tract definitely has a play. Now, for oral medications, presence of food or fat in the stomach normally would slow absorption because, again, the medication gets dissolved, mixed with the food and the fat, and the absorption phase into the bloodstream is slower. There are some medications that we always say to give with food, like oral prednisone. Right? Again, when the oral prednisone is administered, you want to give it with food or milk or something in the stomach. Again, you have to keep in mind that that's going to slow the absorption, but it prevents the ulceration of the GI mucosa because of a property of prednisone is very irritating to the stomach. Motility, again, if foods pass fast. If the patient is having diarrhea, the motility in a transit goes fast through the stomach, the small intestine, into the large intestine, and out through excretion. So again, the absorption may be altered if someone is taking oral medications and they are experiencing diarrhea. Next, we're moving into pharmacokinetics, the distribution phase. It's when movement of drugs goes from the blood into the tissues. In order for drugs to move into the tissues, they have to stay as a free drug molecule. There are proteins out there, and drugs have an affinity to bind with proteins. You have to remember, only unbound drugs can move into the tissues itself. So a lot has to do with protein levels, albumin levels, in how much of a medication transfers into the tissue or the target tissues. So you can see here a plasma is in the capillaries. These are the tissues outside. A free drug moves easily into the tissues, but a protein-bound drug bounces and can't move into the tissues because it's too large of a molecule. We have the blood-brain barrier that alters drug distribution too. You have to remember, your blood-brain barrier is there for a reason. It prevents microorganisms, environmental toxins from entering into the brain tissue itself. Only lipid-soluble drugs could cross. Water-soluble drugs cannot cross the blood-brain barrier. So when you're administering medications and you want it to get into the blood tissue itself, make sure that it's a lipid-soluble drug in your drug guide as you look up the medications. Inflammation in early neonates, the blood-brain barrier is not developed as fully developed, so more microorganisms and toxins can cross over into there. Next phase of pharmacokinetics is metabolism. This is when the drug undergoes biotransformation. Most drugs are metabolized in the liver, and made through metabolism, the drug is made ready to be excreted in the urine. Most drugs are passed to the kidneys for excretion. Cytochrome P450, you may have heard about a little bit before. This is an enzyme that directly affects the metabolism and excretion of drugs. So you have substrates, you have inhibitors, you have inducers. And again, an inducer is going to speed up the metabolism of the drug. So again, the person's duration of action of the drug may be less. And there's enzyme inhibitors, and these are a list of the substances in your textbook that identifies the inhibitors and the inducers and the substrates. With the substrate, you have two drugs that are competing for the same binding site, and this is when you're going to have drug-drug interaction. If you have two drugs and they're both in their substrates, that means one drug may have more of an effect than the second drug. Enzyme inhibitors is going to decrease the metabolism of the drug, which means the drug is going to stay in an active format longer. Next we're going to talk about is the first pass effect of oral drugs. Some medications will go under the first pass effect. Medications are taken by mouth, passed through the stomach into the small intestine, and then the absorption phase is going into the hepatic portal circulation, passes through the liver, and begins to be metabolized, and then goes into an inactive drug conjugate, which goes out to systematic circulation. Certain drugs are known for the first pass effect. Again, you would have to, and it will tell you, this is a reason why a lot of these medications are not able to be given orally. Next is excretion. This is when the drug is excreted, removed from the body, and then most likely it's the kidneys that are going to be excreting the drug after it's been metabolized. If someone has kidney failure, obviously it's going to be a slower process, and the effect and the duration action of the drug may be longer than if someone had normal kidney function. It can be excreted by glands. You know, some medications pass through breast milk, so you have to be worrying if you're on an antepartum, postpartum unit. You have to worry about the drugs that the person is getting, because it can be excreted through breast milk and some sweat glands. There's the barium, again, it's excreted through the GI tract. Now let's look at another aspect. Again, you do come in contact with clinical practice. It's called the time-response relationships. This is talking about a therapeutic range of a drug where it has its most desired effect. It's the peak and trough, and I'm sure those of you who have been given antibiotics in clinical practice have been using the peak and trough aspect of a medication. So again, a toxic concentration you don't want is when the level of drug that goes into serious adverse effects. The goal of you is you want to make sure the drug is within the therapeutic range by getting peak and trough levels of a medication. A half-life provides an estimate of the duration of action. Again, a plasma half-life decreases by a half each time. If a drug is known to have a short half-life, it has to be given more frequently. If it has a long half-life, the drug is given less frequently. And lots of times in your drug guide, it's going to tell you what type of half-life it has. Again, here you can see a medication that's been given. Then these are the hours along the bottom. Duration of action is from 2 to 8 hours, with the peak being here right in the middle. All right, here's your therapeutic range. This is your peak level. So if a physician orders a peak level of, say, digoxin, you want to give it at the peak level, the highest level. And then again, peak and trough is here, down at the bottom. Again, this talks a little bit more about peak and trough levels. A loading dose is when you want to prime it and give a high dose to get the effect sooner, and then the maintenance doses want to keep it within the therapeutic range.